Hello, I'm Professor Patak from Monaco, head of the Department of Cardiovascular Medicine, and I'm really pleased to present at the ESC Congress 2020, the Digital Experience. My presentation is entitled Treatment of Hypertension from Guideline to Practice. Now, my disclosures are as follows. The first thing I would like to share with the audience is based on the European guidelines, who do you need to treat when you face a hypertensive patient? Well, basically the message out there is very clear. Any hypertensive patients defined, and you've listened to the previous talk, the diagnostic part for hypertension, but any patient who's having hypertension with office blood pressure above 140/90 will be a candidate for treatment for his disease. Among some specific features, keep in mind that elderly hypertensive patients who are above 80 years old will have a different threshold. Office blood pressure needs to be slightly higher, 160/90, but you will not deny a treatment in this patient. And finally, there's also a new category of patient, those we call high normal blood pressure patient. You see their numbers, they are just below the target of 140/90, but when these patients are having elevated cardiovascular risk, then they are a good candidate for the treatment of their elevated blood pressure. The second question you might ask yourself is, when do you start to treat these hypertensive patients? Well, I told you, if you face a patient with high normal blood pressure, you will start to offer him lifestyle advice. And this is a general message. You will always start with lifestyle advices, whatever the stage of the disease. If your patient is having grade 1 hypertension, you will offer him lifestyle advice, but also start treating him with antihypertensive drug. And when your patient is entering into grade 2 or grade 3, then there is an emergency to start immediately with drug treatment in all these type of patients with the aim to control blood pressure at a rate of at least 3 months of follow-up. The other question, which is a very practical question, once you have identified this patient, you are ready to treat them, how low should you go? Have there been changes according to targets you need to reach in these hypertensive patients? Well, again, the general message is that if you start to treat this patient, you should be able to lower blood pressure below 140/90. Let's say that this is the general message. Now, in patients below 65 years old, the target will be slightly lower, 130/80, while in patients above 65 years old, you will try to target a blood pressure of 140/80. So a very practical message. You start to treat any patient and try to bring him down to numbers who are below 140/90. You try to be more aggressive in young patients, less aggressive in patients above 65 years old. But also keep in mind that blood pressure should never be too low. If you go below 120 millimeters of mercury for systolic blood pressure or below 70 millimeters of mercury for diastolic blood pressure, you are in the red zone. So you do not need to go below this number of 120/70. Now, I told you that the general message out there is when you want to treat this patient, you will always offer them lifestyle changes. And these lifestyle changes have a very high level of evidence, almost always a class 1A level of evidence, whether for salt restriction, for alcohol consumption restriction, but also for the increased consumption of vegetables and fresh food. And finally, also for all the things we're trying to advise our patient, try to control your body weight, try to exercise regularly, and also try to stop smoking. So these are really the basics of lifestyle changes you might offer in any of your patients with hypertension. Now, at the second level of intervention, you will offer this patient a pharmacological treatment, and it is recommended, and that's also a very important message, to start an antihypertensive treatment with a 2-drug combination, preferably in a single pill combination. That's a very important new message. You will treat the patient immediately with 2 drugs, and ideally by combining these 2 drugs in a single pill. There are some exceptions. When you see a frail older patient, you might lower your expectation and so lower the intensity of the treatment, and also in these hypertensive patients, grade 1 hypertensive patient at low risk, where you might start them if needed with a single pill containing a single molecule. Now, the guidelines have defined what they call the core drug treatment strategy for uncomplicated hypertension. The idea is to offer a step-by-step approach in order to decrease blood pressure and be able to reach the target as soon as possible. How? By starting, as I told you, with the single pill combination therapy. It's a single pill combining a RAS blocker with a calcium channel blocker or a diuretic according to the patient profile. If your patient is not controlled, you will add up the drug you have not used again in this triple combination by the use of a single pill, which will be containing a molecule of a RAS blocking agent, ACE inhibitor or an ARB, a calcium channel blocker, and a diuretic. If you are unable to cope and unable to bring the blood pressure down in this patient, you are identifying a patient with resistant hypertension, and you might add up spironolactone starting at 25 milligrams and trying to tailor the dosage to 50 milligrams. So this is, I think, the basics. This is how you want to treat, let's say, all hypertensive patients. This algorithm is also appropriate for patients with target organ damage, with cerebrovascular disease, with diabetes, or peripheral arterial disease. But sometimes, and especially in the field of cardiology, we have patients who are also having other type of target organ damage. For example, hypertensive patient with CAD will be patient where you might be starting with a heart rate lowering agent, whether a beta blocker or sometimes a calcium channel blocker aiming to reduce the burden of ischemic heart disease in a hypertensive patient. So again, you will always try to find a single pill combination. You will start with a dual combination, which in this case, for a patient with hypertension and CAD, will be a RAS blocking agent with a beta blocker or a calcium channel blocker, or a calcium channel blocker with a diuretic, or a beta blocker with a diuretic. If blood pressure was not controlled, you will play by combining at least 3 drugs out of these first bunch of drugs, again in a single pill, and finally add up spironolactone if your patient is still having resistant hypertension. If your patient is having hypertension and chronic kidney disease, well, not a big deal. You will start with the RAS blocker combined with the calcium channel blocker, or a RAS blocking agent combined with the diuretic, a little bit similar to the core strategy. In this particular case, you might switch from a thiazide to a loop diuretic, which are more effective in controlling blood pressure in a hypertensive patient with CKD. And having said that, we will again combine these 3 drugs into a single pill in order to better control blood pressure in this patient with hypertension and CKD. If your patient is having heart failure, well, you will basically treat not hypertension, but heart failure, knowing that drugs we're using in the field of heart failure with reduced ejection fraction are usually blood pressure lowering drugs, a RAS blocking agent and a beta blocker. The RAS blocking agent could also be an ARNI. You will add a mineraloreceptor antagonist. The patient will also be treated with a loop diuretic, usually for his symptoms, and this will be able to reduce blood pressure in this patient. Finally, the last type of subpatient having hypertension in another disease, in this case, atrial fibrillation. In this case, you might want to use a RAS blocking agent combined with a heart rate reducing drug, in this case, a beta blocker, or even a non-dihydropyridinic calcium channel blocker like verapamil or diltiazem, or even a beta blocker with a calcium channel blocker. And again, you will combine this class of agent if your patient is not controlled and you are moving to step 2, combining 3 drugs in a single pill. Finally, I've covered this subject, but you might not be able to control your patient with 3 drugs, and then you are identifying a patient with resistant hypertension, and in this case, you will try to add spironolactone, or maybe try to get the help of a combination of diuretics, or finally go for the help of a beta blocker or an alpha blocker. It's important beyond blood pressure control to control cardiovascular risk factors in your patient with hypertension, but you are familiar with this approach using statin, for example, or offering sometimes antiplatelet agent for patient in secondary prevention. In conclusion, I think that the key message here is when you want to switch from guideline to practice, treat everybody, try to reach the targets have been lowered, Try always to combine drugs with single pill combination therapy, and never forget to manage cardiovascular risk management for your hypertensive patients. With that, I would like to thank you for your attention.